tell me a little bit about this one, Jason.
Well, this is a photo that we use quite a bit in our history here in Pittsburgh. It goes back to the late 1800s when folks were looking for cheap fuel sources to smelt heavy metals. So south of us, southeast, southwest of us, were lead, zinc, big heavy metal mines, and they needed cheap sources of fuel. And up here in Pittsburgh, we had coal, bituminous, dirty coal that was really cheap. And so then began the boom from the mid-1890s through probably the 30s. We had huge population influx from largely Central and Southern Europe, about 35 different languages spoken here. Obviously, it's work that's not very safe. It's not very steady, but it brought this incredible culture to us that survives to this day in its positives and negatives. So we live with generational poverty here. We live with poor educational attainment, poor health outcomes. Across the board, the 9 counties of southeast Kansas generally rank in the bottom, easily in the bottom quartile, many in the bottom 10 for health outcomes and health factors. So it's a wonderful place to live because those same folks brought a lot of ethnic diversity, a lot of Italians, just kind of a very work hard and play harder culture. But we've always believed it's very important for us to be successful in intervening. We have to understand the community in which we operate and the community in which we live and work. And you can't do that unless you know the history and how a thing got to be the way it is.
Very neat. So one of the things that I would think, and this was one of the interesting things watching your quality numbers go up, there's one thing to convince the healthcare workers, the clinicians, the registrars to care. The other, I think, is this cultural thing. You've got such a hotbed there, and the man's man doesn't want to go to the doctor unless they're dying.
Right.
With your numbers going up, you've had to have impacted that culture. And with 35 languages, I'd imagine there's 35 different perceptions of healthcare. How have you managed to reach out to the community and let them know that you really are there for them and try to figure out, okay, if you've got a problem with this, how can I get that same thing done for you in a way that won't offend you or hurt you or would be acceptable? So what are some of the things that you've had to kind of do to bridge those cultural barriers?
Well, one, we are of the community. I mean, we're a community health center in the absolute purest sense of that word. One of the requirements for community health centers is that you have a patient-led board, and we do. But we're people from here. So there's nothing being done to anyone. It's being done with them. So our healthcare providers, not all of them, but many of them are from here. Our staff are from here. So inherently, I think we understand how you operate in this environment. And one of the ways you operate in this environment is you last. You just stick around. Because we have so many hospital systems that, bring doctors in for loan repayment and they're gone in 2 years. And there's no sense of continuity or consistency. And we've just kind of been here. And I think probably after year 9 or 10, we probably hit a tipping point where people all realized, these people are here, I can trust them. So it took being consistent and being here, I think, and a consistent focus on what else can we do. So we started with medical care, then we did behavioral health, then we added dental, then we added pharmacy, then we added patient navigators. So we're out and about and in the community and doing things all the time. And I think it gives us lots of opportunities to demonstrate to people that we really are different, that we really do fundamentally care about improving the health of the communities where we work, that's not just words, that it really matters to us. And so I think that's what's led us to where we are today.
That is phenomenal.